Hello, my name is McCarthy and I am the current hand fellow. I will be talking to you about ultrasound in the hand and upper extremity. So let's prepare for this journey. First, the important thing to know is ultrasound is basically utilizing our technological advancements to assist our knowledge of applied anatomy. So we'll be going over quite a bit of anatomy today as we discuss the utilization of ultrasound. First, we're going to be talking about carpal tunnel syndrome. So this is just a cross-sectional anatomy image of the wrist at the level of the hamate and the base of the first metacarpal, which allows us to see within the carpal tunnel. Right now you're just looking at the tendons associated with the tunnel in association with the median nerve. Here is an image captured from an ultrasound which demonstrates the relevant anatomy, specifically the superficial position of the median nerve in relation to the majority of the flexor tendons just beneath the transverse carpal ligament. The nice thing about ultrasound is it allows you to see the anatomy within the carpal tunnel. For instance, if somebody has a persistent median artery or has a bifid or trifid median nerve. Additionally, it allows you to provide a dynamic assessment of their flexor tendons to see if they have intrusion of the muscle bellies within the carpal tunnel, predisposing them to their carpal tunnel syndrome, or if they have extrinsic factors such as a ganglion cyst or tenosynovitis that are contributing to the development of their carpal tunnel syndrome. Prior studies have been done which demonstrated that a hand surgeon or any physician who wishes to complete ultrasound assessments of carpal tunnels within the office, it's about a 20 patient learning curve in order for them to obtain dexterity at this exam. The next couple slides will be looking at different ultrasound imaging of the carpal tunnel as it progresses in a proximal to distal fashion. So you'll see here in this top right corner with the closed arrows, what it is encircling here is our median nerve, which is of interest. One of the most common sites to be measuring for carpal tunnel syndrome is at the level of the carpal tunnel inlet or the pisiform. So you'll see the scaphoid here and the pisiform located there. Again, the median nerve is between these two arrows. Here you see images of the longitudinal axis of the median nerve as it is traversing beneath the transverse carpal ligament through the carpal tunnel. Again, it is this longitudinal entity located here. One of the things that you'll notice when performing ultrasound is that swelling associated with the nerve secondary to the compression. You'll have some increased hypervascularity, and you may notice some change in the hypoechoity of the nerve secondary to the compression. This study was a review of the utilization of ultrasound for the diagnosis of carpal tunnel syndrome. Of note, Roll et al. Found that the highest sensitivity and specificity for achieving measurements of the cross-sectional area of the median nerve was performed at the level of the pisiform. Erickson et al. Highlighted that the greatest reproducibility of this measurement was at the inlet. Together, they found that the inlet cross-sectional area had the highest correlation coefficient with our electrodiagnostic studies. Based on this review, the highest diagnostic odds ratio for measuring the threshold for determination of the presence of carpal tunnel syndrome occurred when the cross-sectional area was measured to be between 9.5 and 10.5 millimeters squared. The most common utilized diagnostic measurement is 10 millimeters squared. This image provided an ultrasound-based measurement of the median nerve as demonstrated by the crosshatched ellipsoid at the level of the pisiform and scaphoid. Again, this slide provides different views of the median nerve In the top right figure labeled A, you will see the median nerve between these closed arrowheads, and the small circles within are the fascicles of the median nerve. The other two images are of the longitudinal axis of the median nerve. The lower image demonstrates the hypoechoic nature of the nerve that occurs with the associated enlargement with compression. Here is another image of the sagittal anatomy. It's essential that we keep in mind the anatomy of the regions which we are ultrasounding in order to assist us with our diagnoses. Here you can see a demonstration of the measurement of the median nerve's cross-sectional area, both at the level of the carpal tunnel and at the level of the pronator quadratus. You are able to utilize the difference in these two cross-sectional areas to facilitate your diagnosis of carpal tunnel syndrome. The most common way to diagnose is with utilization of the cross-sectional area at the inlet or pisiform level, but you can also utilize the ratio between the carpal tunnel measurement and the pronator quadratus. If the ratio is greater than 1.2, then that can also indicate that the patient has carpal tunnel syndrome. This study compared ultrasound and electrodiagnostic testing for the diagnosis of carpal tunnel syndrome utilizing a validated clinical tool, or the CTS-6. As you can see in the demographic data, they utilized the CTS-6 to distinguish whether the person had carpal tunnel syndrome based on that reference standard or not. Looking at the very bottom line, you can see that there is a distinct difference in the median nerve cross-sectional area at the inlet, which we had previously identified as the area where we should be obtaining that measurement for diagnostic purposes. And unsurprisingly, there is a significant larger cross-sectional area for those with positive CTS-6 versus those with negative CTS-6. When comparing the sensitivity and specificity of ultrasound and electrodiagnostic testing, this slide demonstrates that ultrasound for the utilization of diagnosis of carpal tunnel syndrome does have appropriate sensitivity and specificity in comparison to our standard electrodiagnostic testing in order to utilize it for diagnostic purposes. Here we are able to compare the three diagnostic tests for diagnosis of carpal tunnel syndrome, including electrodiagnostic studies, ultrasound, and the CTS-6. Again, when looking at the sensitivity and specificity of these diagnostic tests best identified in Table 3 at the bottom here, you can see that ultrasound is appropriate for use in diagnosis of carpal tunnel syndrome. Now that it has been verified that ultrasound can be utilized for the diagnosis of carpal tunnel syndrome, the question is whether it has any prognostic value. This study helped provide some insight with regards to the prognostic value of ultrasound measurements. Previously performed studies, including those demonstrated below, did not find any consistency with the measurements of the median nerve to the ultimate prognosis. Domino and Fowler looked at 199 hands of 172 patients and measured the cross-sectional area of the median nerve at diagnosis, 2 weeks after surgery, 6 weeks, and 6 months after surgery. Looking at this table right here, they measured the difference in cross-sectional area at each of these time intervals. One of the hypotheses of this study was that individuals with larger cross-sectional areas preoperatively had more severe disease and would note more improvement following surgical release. This study looked at individuals stratified by their preoperative cross-sectional area and noted the difference in their Boston Carpal Tunnel questionnaire at both at 2 weeks, 6 weeks, and 6 months postoperatively, and they did not note any statistically significant difference in their postoperative outcome in comparison to their preoperative cross-sectional area measurement. Therefore, with regards to carpal tunnel syndrome, we do have the ability to utilize ultrasound for diagnostic purposes, specifically utilizing 10 millimeters squared as our cutoff for our cross-sectional area, or utilizing a ratio greater than 1.2 when comparing the cross-sectional area at the pronator quadratus and the carpal tunnel inlet for diagnostic purposes. However, we cannot use that information for prognostic purposes. Now, with regards to the other common entity of compression in the hand, we're going to be talking about Guillen's canal for ulnar nerve compression. There have not been studies done looking at the cross-sectional areas with regards to ulnar nerve compression at Guillen's canal. However, it is very important to utilize ultrasound if you are concerned that there is a mass, such as a ganglion cyst or another entity, encroaching on the canal, which is causing the symptoms that the patient presents with. The images below demonstrate the ulnar nerve in this closed arrow circle as it is circling near the pisiform within the canal. Figure C shows it wrapping around the hamate. Here is the picture of the ulnar nerve on the longitudinal axis as it is going about the hamate as depicted in image B. However, we can use ultrasound for more proximal compression of the ulnar nerve at the cubital tunnel. One of the concerns about cubital tunnel is that our EMG testing, which we had previously relied on so heavily for carpal tunnel syndrome, is not as effective when utilized for the diagnosis of cubital tunnel. In fact, EMG testing can show negative results when they are still in the dynamic stage of ischemia prior to them having slowed conduction velocity. In fact, Yoon et al. Demonstrated that patients with cubital tunnel symptoms may display normal results, while ultrasound may be able to detect cubital tunnel syndrome prior to electrodiagnostic changes. This is just an image depicting the trajectory of the ulnar nerve in different regions where compression may occur. And again, this is a cross-sectional image of the anatomy just posterior to the medial epicondyle where the ulnar nerve is traversing within the cubital tunnel. Here are two ultrasound images of the ulnar nerve as it is entering into the cubital tunnel, both in a cross-sectional axis and in a longitudinal axis. The next questions that we will be addressing are: what are the diagnostic criteria for cubital tunnel syndrome? This study was a meta-analysis of the utilization of cross-sectional area for the diagnosis of cubital tunnel syndrome. What you will see is that this forest plot below looked at the cross-sectional differences between patients with cubital tunnel syndrome and those without. And this plot demonstrates that there is a significant difference in the cross-sectional area of patients with and without cubital tunnel syndrome. Again, if there is a significant difference between the cross-sectional areas of patients with and without cubital tunnel syndrome, then what should we be utilizing as our diagnostic cutoff? What this forest plot below shows is that where is this cross-sectional area difference most significant? And if you look at the middle of this plot, it demonstrates that at the level of the medial epicondyle is the most significant difference in cross-sectional area, which helps facilitate our ability to diagnose cubital tunnel syndrome. With the knowledge that the difference in cross-sectional area is most significant at the medial epicondyle, and keeping in mind that that area of compression will result in enlargement of the nerve just proximal to this compressed site, what should we use as our cutoff value for the cross-sectional area? And again, if you look at this forest plot, it demonstrates that the most commonly utilized diagnostic criteria is a cross-sectional area greater than 10 millimeters squared. This study by Yoon et al. Was looking to determine if there was a cross-sectional area ratio similar to that utilized in carpal tunnel syndrome to help facilitate the diagnosis of cubital tunnel syndrome. So they utilized the ultrasound to determine the measurement of the cross-sectional area at different regions within the potential trajectory of ulnar nerve compression, and found that the most common site for compression was at the epicondyle, which correlates with the prior study's findings. When measuring the cross-sectional area at different regions within the arm, including forearm, epicondyle, and mid-humerus, it looked and found that there was a distinct difference in the ratio of cross-sectional area, both when comparing the forearm to the epicondyle and the mid-humerus to the epicondyle for controls and patients. So we are able to utilize a ratio for cross-sectional area of 2.8 to help facilitate our diagnosis of cubital tunnel syndrome. The images here demonstrate the ulnar nerve in both its short and long axis. When comparing the images A and C, you can determine that the ulnar nerve has dislocated anteriorly as demonstrated in image C. Figure B shows the ulnar nerve in its longitudinal axis. Again, these are some ultrasound images of the ulnar nerve as it is traversing distally. You'll see in figure B the ulnar nerve passing posterior to the medial epicondyle, and then in figure C it traversing between the humeral and ulnar heads of the flexor carpi ulnaris. And figure E demonstrates the ulnar nerve on its longitudinal axis. Here is a dynamic evaluation of the ulnar nerve, which allows you to determine whether your nerve is sublexing over the medial epicondyle during range of motion. We're slowly making progress. There is a lot of information that can be obtained with the ultrasound. This will not be a complete review, however, it should give a representation of the power of ultrasound and how it is becoming increasingly incorporated in orthopedic practices. We are now going to be transitioning from discussing compressive neuropathies to utilizing ultrasound to evaluate for injury. This study looked at the role of ultrasound in comparison to MRI and found that ultrasound was superior to MRI given the higher resolution that can be obtained of superficial structures. However, ultrasound is limited by the depth of the anatomy which you wish to visualize. And so it should be noted that deeper structures are more difficult for the ultrasound to fully elucidate. Additionally, the ultrasound is helpful for dynamically assessing tendons or nerves and can be helpful in looking at tears to determine whether they are partial versus complete. I think it is worth noting that ultrasound is useful in taking care of a large breadth of our population and can be utilized to help facilitate diagnosis of a number of injuries. Again, utilization of ultrasound really is applied anatomy. The more you know about your anatomy, the more you can utilize the ultrasound to visualize diagnoses beneath the surface. The next couple slides are just some pictures of anatomy, and we'll go further in detail as to what we can visualize utilizing the ultrasound. This is just a picture of the volar surface of the fingers. Again, we'll go in more detail further down the line. Here is an anatomic image of the intricacies of the extensor mechanism. When looking at the tendons of the hand and the wrist, it is important to note what they should look like in their normal appearance, which is a homogeneous, echogenic fibular structure. And findings of tendinopathy would include tendon thickening, some diffuse or focal areas of decreased echogenicity, or anechoic fluid surrounding the tendon itself. If a partial thickness tear is visualized, you will see a focal anechoic or hypoechoic cleft within the tendon and may see some anechoic fluid within the tendon sheath. Full thickness tears, unsurprisingly, will demonstrate a non-visualization of the tendon where it should be, consistent with the site of rupture. Or you may see some heterogeneous hyperechoic hematoma at the site of rupture within the tendon sheath, consistent with a full thickness tear. This is an image of your extensor compartments. We will be stepping in a radial to ulnar fashion through the compartments utilizing the ultrasound. We will stepwise through what these images show. Figure B demonstrates your second extensor compartment in relationship to Lister's tubercle, and your third extensor compartment consisting of EPL as it traverses past Lister's tubercle, followed by your fourth extensor compartment containing your extensor indices and your extensor digitorum. Figure D represents the relationship between your first and second extensor compartments. Figure E demonstrates your third extensor compartment as your EPL tendon traverses superficially to your second extensor compartment. And figure F demonstrates the superficial branch of your radial nerve as it is superficial to your first extensor compartment. These images further elucidate the ulnar extensor compartments. Figure B demonstrates the relationship between your fourth and fifth extensor compartments, and figure C shows a normal appearance of your extensor carpi ulnaris. Here is a view of your extensor compartments in a longitudinal axis. E labels your extensor tendon, while the closed arrows above represent your extensor retinaculum. Here is an image demonstrating the benefits of dynamic assessment utilizing the ultrasound, where we can see your extensor carpi ulnaris tendon as it dislocates ulnarly from its asterisked normal position. We're now going to be turning our attention to our fingers. Specifically, we will focus on the extensor mechanism to begin. I thought this was a simplified slide that helped demonstrate the different levels of the extensor mechanism and what we can expect to see in a cross-sectional area. Here is a nice reminder of the intricacies of the extensor mechanism. Here are some images of your extensor mechanism in a proximal to distal fashion. Figure B demonstrates your extensor tendon as it traverses your MCP joint. Figure D demonstrates the central slip as it is traversing your PIP joint, and figures E and F are demonstrating your lateral slips as they converge distally over the DIP joint to form your terminal tendon. Here is a look at your MCP joint in both a short and long axis, looking at your metacarpal head and the relation of the extensor tendon dorsally. This slide demonstrates some pathology that can be seen utilizing the ultrasound. The top image demonstrates a tear of the extensor indices. I think this is most easily visualized in figure B, which demonstrates the abnormality of the torn tendon in comparison to the intact extensor digitorum tendons. Below is an image of a sagittal band injury. Utilizing figure A, you can determine the difference in the images. The damaged sagittal band is highlighted by the arrows, and in figure B, you are able to distinguish the subluxated position of the extensor tendon secondary to that torn sagittal band. We will now look at the volar surface of the finger, specifically the flexor mechanism. Here are two images demonstrating what we will be talking about. Here are ultrasound images of your normal flexor anatomy. Figure B demonstrates your flexor tendon's relationship at the level of the MCP joint with your flexor digitorum superficialis remaining superficial at this level. The entity identified by the closed arrowheads is your A1 pulley. Figure C demonstrates the relationship of your superficialis and profundus tendons at the level of the proximal phalanx, and the entity identified by these arrows is your A2 pulley. Progressing distally in figure D, you see that there has been a change in the relationship of your flexor digitorum to your flexor superficialis, secondary to your flexor digitorum superficialis attaching at the middle phalanx. The entities identified by these closed arrowheads are your A3 pulley and your A4 pulley. And finally, figure E is just trying to better demonstrate that your flexor superficialis is coming in and attaching at the level of the middle phalanx, with your flexor digitorum profundus continuing distally and traversing over the DIP joint and attaching to your distal phalanx. These ultrasound images demonstrate the changing relationship between your flexor digitorum superficialis and profundus. Figure B is taken at the level of the proximal phalanx, where your superficialis tendon remains superficial, while figure C is taken at the middle phalanx and demonstrates the split in your FDS tendons as it goes to attach on your middle phalanx, and there is continuation of your FDP tendon, which is now superficial to your FDS. I thought this slide highlighted the incredible resolution that an ultrasound can provide with regards to evaluation of the palmar surface of the hand. The figure B shows the relationship of the superficialis and profundus tendons in relationship to the interossei and the lumbricals. While I acknowledge this is a very impressive image to obtain on ultrasound, I will be the first to admit that in my hands, I am not yet capable of that. These images demonstrate some of the pathology that can be assessed utilizing ultrasound. The top image is looking at a partial thickness tear of the flexor carpi radialis tendon, both in a short and a long axis. You can see in figure A and B the changing appearance of the flexor tendon. The below image represents a full thickness tear of the flexor digitorum superficialis, again in a short and long axis. Figure A shows the proximal retraction of the superficialis tendon, and figure B demonstrates its absence in comparison to the adjacent digit. Here we can see an injury to the flexor digitorum profundus. You can see on the distal phalanx labeled with a D that there is a divot missing, and when looking proximally, as highlighted by the arrow, you can see the proximal retraction of the flexor digitorum profundus tendon at the level of the PIP joint. We'll now discuss some anatomy about the elbow. Here are just some images to refresh us. So when looking at the anatomy of the elbow, I am going to focus on imaging of the distal biceps in particular, but also will mention the triceps tendon. Once again, when looking at ultrasound imaging, it is important to remind ourselves what an abnormality should appear like, and it can appear as a thickened or thinning of the tendon, a decrease in the echogenicity and associated fluid. A full thickness tear will once again show an absence of the tendon. It can show some heterogeneous mass associated with the hematoma formation, and it can be utilized to assess the degree of retraction. Here is just a cross-sectional image of the anatomy near the elbow. I wanted to particularly highlight the relationship of the biceps as it approaches distally to its insertion on the radial tuberosity. Here are some ultrasound images of the antecubital fossa, just to refresh ourselves on what a normal anatomy would look like. As they have labeled, you have your pronator teres, your brachioradialis, your biceps tendon, your brachialis, your brachial artery, your median nerve just next to your pronator teres, your LABC right next to your biceps tendon, and your radial nerve beneath your brachioradialis. Looking at it from a longitudinal axis, it allowed us to see our musculocutaneous nerve as it traverses between your biceps and your brachialis. Here are some ultrasound images of the biceps in the short axis as it progresses distally. What you can see in figure C is the relationship of the lacertus fibrosus, which is the arrows with the stem, in relationship to the biceps tendon. These are additional images of the biceps tendon from a long axis as we are viewing it in a proximal to distal fashion until it ultimately attaches to the radial tuberosity in figure F. Here is another way to view the biceps tendon from the medial approach. Again, looking to see the biceps tendon as it comes down to attach on the radial tuberosity. And finally, this is looking at the biceps from a lateral approach. I thought this was a nice way to visualize our surgical anatomy when we are considering reattachment of the biceps tendon to the radial tuberosity and considering the location of the supinator for consideration of our PIN. Here are just some anatomy pictures to once again remind ourselves of what we are anticipating to see within this region with the ultrasound. These images demonstrate a full thickness tear of the biceps. You can see in figure A the torn stump of the biceps tendon. Figure B demonstrates the full thickness tear where the arrow is located, where there should be a consistent attachment of the biceps tendon. And figure C allows us to assess for the retraction of the tendon stump. Again, this is another biceps tear. However, this one is not retracted like the previously identified. I think that is best represented in figure A, where you can see the stump very near its intended insertion on the radial tuberosity. These images represent a partial thickness tear of the biceps tendon. Both demonstrate a tear of the short head and an intact long head. I think the best image to see this is figure A, where you can see the intact portion attaching to the radial tuberosity and you see the torn short head. Continuing our discussion about the elbow, we'll be discussing the ulnar collateral ligament and the utilization of ultrasound to identify acute partial and full thickness tears versus chronic injuries. Here are some anatomy pictures of the ligamentous structures about the elbow to remind us as to what we will be discussing. This image demonstrates a partial thickness tear of the proximal ulnar collateral ligament. And here would be a full thickness tear where you can see the complete gapping on this coronal view. This study looked at the role of ultrasound for evaluation of the ulnar collateral ligament in throwing athletes. The most common angle of flexion to utilize for study is 30 degrees. This angle has been found to be the most sensitive and specific for dynamic assessment. You need to be sure to eliminate gravity for your baseline study. And it usually only takes about 3 to 5 pounds of force to achieve maximal joint opening that a patient can tolerate. This is a compilation of studies that have been performed with regards to evaluation of the UCL ligament. Again, it just represents that the most common angle of flexion for assessment is at 30 degrees. When you're assessing the stability of the ulnar collateral ligament, you are measuring the joint gapping at the ulnohumeral joint. A normal amount of laxity seen in throwing athletes is 1.3 to 1.4 millimeters. If you're noticing a gapping of greater than 2.4 millimeters, that is associated with an injury to the ulnar collateral ligament. When comparing the injured to the non-injured side, a difference of greater than 1 millimeter is indicative of an injury to the UCL. Once again, a reminder of the anatomy that we are evaluating, and in particular on the UCL, it is this anterior bundle that is the most problematic. Here's a demonstration of normal UCL anatomy. The UCL is represented by these closed arrowheads as it traverses from the humerus to the ulna, and above you see the common flexor tendon and its associated musculature. Here are some ultrasound images demonstrating a partial thickness tear and a remote injury. Figure A shows this abnormal hypoechoic region within the UCL tendon, while figure B demonstrates a partial thickness tear at its origin. The figure in the lower right corner demonstrates a remote injury where you can see along the longitudinal axis the attenuation of the UCL ligament. Here is demonstrated a full thickness tear as shown in figure A, and figure B shows the abnormal joint gapping associated with valgus stress. We spent the last couple minutes focusing on the medial aspect of the elbow, so I wanted to provide some anatomy with regards to the lateral aspect of the elbow. Here are some ultrasound images demonstrating normal anatomy of the lateral aspect of the elbow. Figure B demonstrates the radial collateral ligament, the annular ligament, and the overlying extensor musculature. Figure B shows the common extensor tendons as they traverse the radial head, and figure D represents the lateral ulnar collateral ligament as it traverses from its origin on the humerus to its ulnar insertion on the crista supinator. Here's some pathologic ultrasound images. Figure A demonstrates an abnormality within the radial collateral ligament. Figure B represents pathology within the annular ligament. And figure C demonstrates injury to the lateral ulnar collateral ligament. This smaller inset image demonstrates tendon abnormality within the common extensor tendon and damage to the radial collateral ligament. All right, so you've been overloaded with information of everything that you can see utilizing an ultrasound, which with regards to the hand and upper extremity, where most tendons and ligaments are superficial, is all of applied anatomy. So what can we talk about next? And I just briefly wanted to touch on the fact that ultrasound is now not only being utilized to diagnose pathology, but is also being utilized to help us perform procedures. In particular, we will be discussing trigger fingers and carpal tunnel syndrome. So this first study looked at the utilization of ultrasound to release trigger fingers versus a classic open surgery. It did a randomization of patients to either the classic open procedure or the ultrasound assisted pulley release. Here are just some images. On the left demonstrates the utilization of ultrasound versus figure B, which demonstrates the classic open procedure. Here are some ultrasound images showing the two different techniques that can be utilized for ultrasound guided releases. Figure A shows the utilization of a 16 gauge needle, while figure B shows use of the hook knife. This study directly compared 4 postoperative variables, including the ability to stop using analgesics, ability to obtain complete digit extension and flexion, and the ability to return to normal daily activities. Table 1 demonstrates that individuals who underwent ultrasound guided releases noted a shorter duration of analgesic use, fewer days to obtain complete digital extension and flexion, and fewer days to return to normal activities in comparison to our standard open procedure. Table 2 looked at postoperative grip strength, and it was noted that there was significant improvement in grip strength at 1 week. However, by 3 weeks postoperatively, the change in grip strength was no longer statistically significant. Lastly, this study looked at the utilization of ultrasound for release of the carpal tunnel. And again, it compared a mini open carpal tunnel to the Ultra MIS, which was the utilization of the ultrasound for release. Here is an image of their technique. That dot highlighted by the blue arrow is their incision site for the ultrasound guided release. Here are 2 images looking at their release from both a transverse and a longitudinal perspective while highlighting the pertinent anatomy. This slide represents the different postoperative outcomes in the 2 groups. Table 1 demonstrates that individuals who underwent an ultrasound guided release utilized oral analgesics for a shorter period of time, were able to more quickly regain complete wrist extension and flexion, and were able to more quickly return to their normal daily activities. There was no difference in time frame for relief of paresthesia. Table 3 demonstrates that individuals who underwent ultrasound guided release had less postoperative pain. After 6 weeks, they were equivalent. Here we look at the difference in quick dash scores, and as is visualized in the accompanying figure, you can see that there is a statistically significant improvement in quick dash scores in the ultrasound guided release at all time points until 12 months. There was no association with ultrasound guided release and improvement in grip strength. Thank you for sticking with me throughout this presentation. It was a rather broad topic, and I hope to have at least highlighted some of the ways ultrasound can be utilized for not only diagnostics but procedural purposes. As the resolution of ultrasound continues to improve and ultrasound machines continue to become more cost-effective, I foresee that ultrasound will have an increasing presence in an orthopedic practice. The visualization of our anatomy with an ultrasound may seem like magic, but in reality it's just utilization of our applied anatomy, and it is quite impressive to be able to enhance our diagnostics utilizing this tool. I hope you found this presentation to be beneficial and can hopefully take something home with you to your own practices. Again, thank you for listening to this presentation, and I hope you have a good day.